Good evening. I'll be talking about what new are we doing in retinoblastoma over the last couple of years and what we currently do. I'll be skipping about intraarterial chemotherapy because that has already been spoken about. I'll be touching a bit on classification, focal therapy, management of vitreous seeds, and orbital retinoblastoma, that's new. We are all aware of international grouping of intraocular retinoblastoma and international staging system. What is new in classification is addition of H to the alphabets TNM. TNM is tumor node metastasis classification. AJCC 8 adds H, that is heritability, just bringing in genetics to the forefront in the management of retinoblastoma, especially in terms of screening of retinoblastoma, where heritability becomes very important, as well as in selective implantation. In focal therapy, we had cryotherapy earlier. For example, a small tumor of this sort would produce a large scar. And these scars are sometimes dangerous because they can have atrophic retinal holes resulting in rhegmatogenous retinal detachment. Also, if the scar is temporal to the macula fovea, then there is a risk of epiretinal membrane formation, foveal distortion, etc., thus precluding good vision. Photocoagulation is no longer done because of the large scar that is produced. Right. Okay. So you can see that a tumor is surrounded by two rows of large diameter laser burns that results in a much larger scar, and also there is a chance of vascular occlusion. So photocoagulation is no longer performed, and what is currently performed is transpupillary thermotherapy, which is performed directly on top of the tumor. Thus we have a very crisp scar, and the blood vessels that are passing through the area are classically patent. It does not cause visual disturbance. Now, what is new in TTT is photodynamic therapy, where we use the synergistic effect of indocyanine green in the wavelength with semiconductor diode laser to treat recurrent tumors on top of a amelanotic scar. For example, this is the scar that we always had, and on top of that, this patient has a local tumor recurrence. Obviously, when we do standard TTT, there will be less take of laser in that area. When we combine it with ICG, you can see nice regression following ICG enhanced transpupillary thermotherapy. For tumors which otherwise cannot be treated with chemotherapy for systemic reasons, etc., or ophthalmic artery stenosis, where we cannot reliably do intraarterial chemotherapy, we can do plaque brachytherapy in these patients. The notch plaque actually sits right next to the optic nerve and is able to treat tumors which are juxtapapillary. In this patient, the tumor was overhanging the optic disc. When we use a notch plaque which sits around the optic disc and covers the rest of the tumor, you can get a nice scar of this sort. One more tumor which was juxtapapillary treated with notch plaque. So plaque is currently made in India, which has reduced the cost to less than 5% of an imported plaque. Intraarterial chemotherapy, as Bhavna emphasized, makes a huge difference in group D and D retinoblastoma. I'm not going to talk about it. Vitreous seeds were a major bugbear in the management of retinoblastoma. There are many types of seeds. The classic vitreous seeds, as always we knew. Now we have prehyaloid, subhyaloid, epiretinal, intraretinal, and subretinal seeds, which is OCT based classification. And also intracameral seeds, which are depository, which simply come through the zonules and get deposited into the anterior chamber. And infiltrative are the ones which come through infiltration and contiguous infiltration of the ciliary body, anterior chamber angle, and the iris. How do we treat these seeds? Initially, we started treating them with safety enhanced intraocular melphalan injection. It showed good results. You can see a bunch of seeds gone with a couple of injections. But after we started treating patients who had extensive vitreous seeds with multiple injections of melphalan, as was described in the international protocol, we started noticing that Indian eyes would have these retinal pigment epithelial changes, which obviously, if it occurs in the macula fovea, a patient may not have good vision. And also these patients tend to have a higher chance of posterior subcapsular cataract and of posterior synechiae, thus causing a bound down pupil, thus precluding visualization of the tumor. So we shifted over to intraocular topotecan, which is a spaced out injection. Instead of a weekly injection of melphalan, we give it every 3 weekly, fewer injections, and hardly any retinal toxicity. This is a patient who was treated, the first case that was treated with intravitreal topotecan, couple of injections 3 weekly, good results. Similar patients 2 doses of topotecan. So we need fewer injections. Again, this patient has completely calcified using topotecan. Fewer injections, less spaced out. What if you have a refractory situation? This patient presented with this large tumor and then a bunch of vitreous seeds. After intravenous chemotherapy, the tumor has regressed, but the vitreous seeds remain almost the same. Then we bring in topotecan. 6 injections later, they're less, but they're still there. So we add a low dose melphalan, starting with 10 milligram, and if it does not respond, 20 milligram, not 30, the standard dose. And with a combination of topotecan and melphalan, you can see that the seeds went away. But even with 20 micrograms, you can still see that there is RPE change already. So retinal pigment epithelial changes are imminent to use of melphalan, and it should be used in low doses and very cautiously. In intraocular chemotherapy, there are extended indications as well. Patients who had anterior chamber seeds were earlier not differentiated to be having just depository seeds or infiltrative, and they would be enucleated. Now we do UBM in all these patients to see if they really have a ciliary body extension or not. Under anesthesia, it's very easy to do UBM, and once we confirm that there is no ciliary body invasion, we can treat these patients with intracameral chemotherapy with a very low dose topotecan. 5 microgram is what is used. If a patient indeed had ciliary body extension like this patient had, where the other eye had already been enucleated, this was the only potentially seeing eye this patient had, and he had a ciliary body extension. You can see the D-shaped pupil indicating that iris was infiltrated clinically. Of course, we treated this component with plaque brachytherapy, and for the seeds we gave intracameral topotecan, and both these components went away, and the child is doing very well after 4 years of follow-up. So this is something heroic, but of course it has to be tried in patients where the other eye has already been enucleated, because this is the only option. As a corollary, we also started finding that this massive subretinal seeds that this child had regressed with intravitreal topotecan. So for subretinal seeds, where earlier we were doing extensive TTT, which would have resulted in a large scar in this area, now has a chance of resolution with just injections without having to do TTT at all. Now about orbital retinoblastoma, where clinically we can diagnose because the child presents with proptosis, or radiologically when you do MRI you find that there is orbital extension. Earlier we were doing orbital exentration with about 70% mortality. Now with multimodal therapy, where we begin with neoadjuvant chemotherapy, where the orbital component regresses, and after complete radiologically evidenced resolution of orbital component, you do an extended enucleation and then stereotactic radiation, and finally adjuvant chemotherapy. These children have a much better chance of survival. This patient has complete optic nerve involvement right up to the orbital apex. Almost impossible to enucleate it primarily without leaving orbital residual. After neoadjuvant chemotherapy, you can see that optic nerve caliber has completely normalized, and we got a normal stump, unaffected stump following enucleation in this situation. Anterior intracranial extensions were earlier only treated with palliative therapy, where nothing else could be done. But now we have a chance of survival for these patients. This patient with cavernous sinus involvement massively now has resolved following neoadjuvant chemotherapy, and what is left is at the superior orbital fissure, which is easily amenable to treatment with stereotactic radiation. Cosmesis is a big bonus in these patients. Patients don't need orbital exentration, and with just an extended enucleation, these patients are still able to use ocular prosthesis, a customized ocular prosthesis. One more patient with an exactly similar situation, where the entire eyelid involvement has normalized following multimodal treatment, and the child is good with a custom ocular prosthesis. Orbital OB also can now be cured. With all this put together, our survival rates range to from 95 to 96%, not as good as 98%, which is seen in the best of Western centers, but still we are working towards it. So what has really transformed the management of retinoblastoma is the understanding of neoadjuvant therapy, adjuvant therapy, and multimodal treatment that actually has a bearing on life salvage. For eye salvage, we have intra-arterial chemotherapy and intravenous chemotherapy, and newer designs of plaque brachytherapy added on. And for vision salvage, of course, we have intra-arterial chemotherapy, intravitreal topotecan, and photodynamic therapy.